Okay, we're going to talk more about managed care in health insurance. Again, some of the characteristics of health plans, managed care, fee-for-service. Fee-for-service plans use a fee schedule of covered procedures and services. So anything that has a CPT code is mapped to a certain amount of reimbursement. It gets put on the bill, the CMS 1500 bill, the bill is submitted, payments made, and away we go. Value-based reimbursement is something that's becoming much more popular. And basically this is compensating provider offices based on quality of managed care measured by patient outcomes. And these are things like some of the HEDIS measures that we see. So in other words, if you have a diabetic patient, how often have they been screened for diabetic retinopathy? How often are you checking their A1C? All these different types of things. The third-party payers are the commercial plans, the Blue Cross, the MODA, what have you. Government plans. Of course, the largest payer, of course, is CMS. Disability insurance, workman's comp plans, the Aetnas, Aflac, all these different types of things. And in many cases, these health plans and managed care are similar. For example, they have primary care providers and do utilization management, which we're just going to talk about in a little bit. Primary care providers are basically your family doctor, and they supervise and coordinate all the services for people in their panel, as they say. Anytime a patient needs a referral to a specialist for, say, a surgical, urological, GYN issue, they refer to the specialist. In the old days, primary care providers used to follow their own patients in hospitals. Now they have hospitalists that take care of the patient while they're admitted and in the hospital itself. So a little bit of a change in the last 25 years. With many of you, if you have a health insurance plan, say by MODA, you're asked to select a primary care provider. The idea is that your care is more effectively managed with the primary care provider, and therefore you're rewarded with that by paying out less money in copays and what have you. When we use the term physician referral, this is something in writing that is written up by a primary care provider that facilitates a patient getting seen and treated by a specialist. So if you want to go and be seen by a sports medicine provider at Slocum, your primary care will do a written referral. It will be sent over electronically with them. Usually they'll have some sort of pertinent information, rate, injury. Sometimes they'll send imaging if it's appropriate, what have you, and the patient gets seen. The primary care provider essentially acts like a gatekeeper. So by doing this, and you don't want to have the specialist getting flooded with everybody who has some sort of complaint, that some of these things can be managed outside of the realm of specialty care. And they give incentives. There are payments made to providers to limit services. What this does is save the insurance plan money. Government plans provide mandated language in their plan disclosure documents that all these incentives have to be put in writing. Now, of course, we have care paid for by an insurance company, but increasingly the amount of reimbursement is being tied to quality. So how do we measure quality? This is where quality assurance and performance measurement comes in. Quality assurance, also referred to as a quality management program, are activities that assess quality of care that's provided. This may involve nurses reviewing records to see if appropriate levels of care was provided if things were being done in an inefficient way. For example, if somebody's kept in the hospital because they didn't, an extra day because they didn't have access to a skilled nursing facility, those different types of things. So it's with the goal of managing patients at the most appropriate level of care. Performance measurements are criteria that strengthen organizational accountability. So basically, it's criteria that evidence-based treatment guidelines are being followed, that we're not just writing for patients to get diagnostic tests that don't impact their care in a meaningful way. And then oversights done by external quality review organizations, quality improvement organizations, and ultimately, in the case of managed care organizations, such groups as NCQA and TJC. One of the ones we hear a lot more about in health information in the last 25 years is the National Committee for Quality Assurance, or NCQA. And basically, these do surveys to assess the quality of managed care plans. They have essentially what they call the report cards. And these are the documents that we see sometimes. Kaiser Permanente likes to say our report card says we're a 5-star plan, all this other different type of thing. NCQA is the author of the Healthcare Effectiveness Data and Information Set, which we call in the trade HEDIS. HEDIS is a great way for health information management students to do chart reviews and get familiar with health information. And a lot of times these agencies that do HEDIS data collection will be hiring for health information management students, and I'll be posting that job information as it becomes available. And of course, everybody knows what standards is. Standards are basically the things we have to meet in order to be accredited. We talk about utilization management. It's kind of linked to quality assurance and quality management, but it's a way of controlling cost and quality of care. If you think of healthcare as kind of a continuum, where at one end we have the medical office, and the other end we have the ICU, there's a range. So the idea is we want to work on that range and keep the patient at an appropriate level of care. And by doing this, we control cost and we improve care. This involves both prospective and retrospective review of medical records. The people that work in quality assurance and utilization many times in hospitals will be combined, but they're basically going to be doing a lot of record review. They're going to be looking at efficiency, effectiveness, and medical necessity. And some of the things they also look at is what is the pre-admission criteria? In other words, pre-admission review. When the patient's in-house, they'll be doing concurrent review. And then once they're out, they do discharge planning. One of the things that we found a lot of many years ago in healthcare is once people were discharged from the hospital, they would be coming back because they didn't have adequate discharge instructions, follow-up care, home health, what have you. And the idea with utilization management is to keep those costs down by reviewing records, doing appropriate discharge planning, and so on. Utilization review organizations are basically agencies that do these types of reviews for managed healthcare plans. Case management is taking utilization management to a new level. And basically, it's developing a multidisciplinary patient care plan that coordinates care, provides care, manages complicated cases, and assures that the patient's getting the most cost-effective service without sacrificing quality. I'll give an example of this in just 1 minute. The case manager authorizes the treatment and provides written communication to both the provider, the managed care plan, and coordinates services to improve the outcomes. When I worked for Kaiser Permanente, this was one of the areas that they felt they were the leaders in with heart failure case management. So with heart failure, one of the criteria we look at with patients is weighing them to make sure that they're not picking up weight so they don't have to go back into the hospital and be admitted through the ER and so on. And the case manager would be reaching out to the patient, reaching out to the pharmacy, and basically coordinating all these services so the patient can be out of the hospital and have a better quality of life. Second surgical opinions are common. And basically, if somebody says that you need surgery, you should always ask for one to evaluate, is the surgery needed? Most insurance payers will pay for these. And again, while you may in fact need surgery, what type of surgery and where it is also a factor. Some of these procedures can be done in the same day surgery office or physician's back office instead of going into the hospital, which is typically more expensive. When we have a second surgical opinion required by a payer, something that if you've taken CPT coding, modifier 32 on the CMS claim form, and then the EMN service is going to be as a new patient visit. It will not be a consultation. And that's all I have for this lecture. We'll be finishing up more on insurance, managed care plans, and other items in the next lecture.